I'm Dr. Anish DL, consultant neonatologist at Believers Medical College, Tiruvalla, Kerala. I'm also a certified neonatal transport provider, having completed the STAN course by Neonatal Transport Service, London. Today, we will take a look at the stabilization and transport of neonates, a journey through its evolution, organization, and execution. We shall explore how neonatal transport has evolved from this ancient conceptualizations to this sophisticated evidence-based system that prioritizes the safety, stabilization, and family-centered care. The practice of transporting critically ill newborns has a fascinating history. Even as early as the 6th century BC, Greek mythological references are there about neonatal transport. The god Hermes is said to have carried the premature infant Dionysus to Mount Nysa, where the nymphs created a primitive incubator made of vine branches. Its double-walled design helped maintain the warmth and temperature stability. Remarkably, those are the very principles which remain at the heart of this modern neonatal transport, maintaining thermoregulation and stable environment. Fast forward to the 2nd century AD, where Sweranus laid the foundation for systemic neonatal assessment. He proposed criteria to decide which infants were viable for further care based on their physical condition and gestational maturity. This represented humanity's first structured attempt at neonatal evaluation. By the mid-19th century, neonatal care took a major leap forward. In 1857, Jean-Louis described the first heated chambers for preterm infants, the forerunners of incubators. Then in 1878, French obstetrician Tarnier revolutionized neonatal care by creating the first closed-type incubator inspired by poultry chambers. In 1898, the Americans soon caught up. Dr. Joseph D. Lee established the first incubator station in Chicago and designed a hand ambulance, which was an early portable version built from oak, heated with hot water cans and metal jackets. And in 1914, Dr. Hess developed the Hess portable incubator, a compact leather-covered box with oxygen ports, the first commercially produced transport incubator. These milestones laid the groundwork for the principle that underpins all neonatal care today. The transport environment must replicate hospital conditions as closely as possible. The modern transport incubators have evolved into highly integrated systems that ensures safety and stability during the most challenging transfers. They feature servo-controlled temperature regulation, mounting systems for ventilators and monitors, battery power backup, and vibration isolation designs to minimize motion stress. As you can see in this picture, this particular transport incubator can provide therapeutic hypothermia and can deliver INO on the go, apart from various modes of ventilators available in that particular incubator. We are in this era where ECMO can be provided while transporting a baby from point A to point B. Modern neonatal transport demands precise and comprehensive equipment. Let's briefly outline the essentials. Respiratory equipment including oxygen delivery systems, portable ventilators, CPAP systems are necessary. Airway management kits with self-inflating bags, endotracheal tubes, and laryngoscopes must be a part of transport. Monitoring equipments for ECG, pulse oximetry, non-invasive blood pressure, and temperature are also a must. These should be there as a checklist. The transport team should have vascular access supplies such as IV catheters, umbilical lines, and intraosseous access. They should also carry medications and fluids ranging from the resuscitation drugs like epinephrine to maintenance fluids, sedation, and vasoactive infusions. Each piece plays a vital role in maintaining physiological stability throughout the transport continuum. Now, how can we categorize neonatal transport? Inter-hospital transport, the most common one, this involves movement to a different center for intensive care or specialized procedures. Intra-hospital transport, this occurs within the same facility. These are often short in distance but carries unique risks of its own. Home to hospital transport becomes a critical part of resource limited countries like India, or when there is an unexpected home delivery. But what is the safest them of all? The safest transport incubator is the mother herself. In utero transfers, whenever possible, offers the best outcomes. This reduces the neonatal mortality and prevents the physiological stressors of postnatal transport. Now, what are the most common indications for a transport? These indications are many, and most common ones are consistent across the globe. These include prematurity of or low birth weight, respiratory distress, asphyxia or neurological issues, cardiac or circulatory compromise, surgical or complex congenital anomalies. Now we have come to the modes of neonatal transport. The transport may be by ground or by air, depending on the geography and urgency and the distance. Ground transport remains the most prevalent mode, particularly in countries like India. For ground system, some of these are vital. Secure fixation of the incubators and equipment. Vehicles should be equipped with independent power sources and adapters to maintain uninterrupted care. The speed should be optimized as well. Typically, it should be around 20 kilometers per hour above the posted limits, and it has to balance the safety and the timeliness. Safety standards mandate that all equipment and personnel be secured to withstand up to 10 G force in all directions, forward, backward, lateral and vertical. Air transport, on the other hand, includes rotary wing helicopters for distances up to around 300 kilometers and fixed wing aircraft for longer journeys. While air transport offers speed and smoother travel at an altitude, it introduces its own unique challenges, especially pressure-related physiological changes, which must be very carefully managed. We shall look into this later on in our slides. In resource-constrained regions, innovation and adaptability become essential. When advanced transport systems are unavailable, care providers rely on improvised containers like thermocol boxes lined with cotton or kangaroo mother care for thermal stability through skin-to-skin contact. These methods, though basic, emphasizes an important truth. The heart of neonatal transport lies not in the technology but in commitment, preparedness and physiological awareness. Now, how to go about the transfer itself. Successful neonatal transport depends on an organized system built on three pillars: identification of appropriate receiving hospitals, reliable communication infrastructure, and specialized trained human resources. The transfer process begins with the referring physician identifying the suitable facility, often through an established network or direct professional communication in conjunction with the parents. But what truly determines success is the quality of communication between all involved parties. A structured model known as IS bar, identification, situation, background, assessment, recommendation, and readback or response, ensures clarity and safety in communication during transport. For example, hello, this is Dr. Anish from NICU District Hospital. I'm calling about a baby a 3-day-old male currently in our NICU preparing for transport to your tertiary center. This identifies both the caller and the patient. The situation then describes the reason for the referral, such as a suspected congenital heart disease. The background provides essential history and interventions given so far. The assessment summarizes current status and stability. The recommendation outlines what we have done so far and what the next steps are, while the readback confirms understanding of the other person. This simple framework prevents miscommunication and establishes shared situational awareness, critical in high-stake neonatal transfers. Speaking of frameworks and models, the ACCEPT model offers a systematic framework for executing the transport process. Assessment determines the infant's clinical issues, responses, and timing for the transfer. In control, we are designating a team leader who then assigns roles and establish authority lines within the transport team. As we said earlier, communication is one of the foremost thing and most vital things, and if possible, use a tool like IS bar. A proper evaluation of the patient stability has to be made both before and after transfer. Preparation, we have to ensure both clinical and equipment readiness with clear documentation, and conduct the transfer with ongoing monitoring and continuous updates. This model emphasizes that organization and coordination are just as vital as our clinical skills. The most important part of any transport is stabilization of the baby before the transport itself. It doesn't matter how fast we can transfer the baby from point A to point B. Inadequate stabilization remains the leading cause of transport-related complications worldwide. The goal is to minimize the physiological stress and get stability before the movement begins. The pre-transport stabilization can be summarized by STABLE acronym. STABLE stands for sugar, temperature, airway, blood pressure, labs, and emotional support, each representing a vital component of transport readiness. We'll explore this in depth here onwards. Let's begin the first component of the STABLE framework, sugar. Maintaining the blood sugar within the safe range of 60 to 160 milligram per deciliter is crucial. Hypoglycemia can occur quickly in neonates during transport. This can be due to stress, cold exposure, prolonged fasting, etc. We start by assessing the risk factors such as prematurity, small for gestational age, maternal diabetes, birth asphyxia, hypothermia, and poor feeding. Venous access should be established before the departure itself, and glucose containing IV fluids administered to prevent hypoglycemia whenever indicated. The continuous monitoring throughout the journey ensures that any fluctuations can be promptly corrected and should be done so. Next is temperature, one of the most critical determinants of neonatal stability. Newborns, especially preterm infants, lose heat rapidly due to their large surface area and immature thermoregulatory mechanisms they have. Hypothermia is most common and dangerous, often leading to metabolic acidosis, hypoglycemia, and increased mortality. The key steps to prevent hypothermia is by raising the environmental temperature to 25 and 28 degrees during this preparation for transport. Use preheated warming devices. wrapping these extremely premature babies under the polythene sheets to minimize evaporatory heat loss. Ensure the transport incubator is fully pre-warmed before placing the baby inside. The goal is to maintain a core temperature between 36.5 and 37.2 degrees Celsius throughout the transport process. Ensuring a clear airway and adequate respiratory support is essential before the transport begins. We start by assessing the airway patency. Oxygen saturation should be maintained between 88 and 95%, avoiding both hypoxia and hyperoxia. If the infant requires intubation, it should be done before the transfer itself. It should be securely placed and the tube position should be confirmed before the departure. A gastric tube is inserted to prevent distension. While intubation provides stability for long or high-risk transports, it can also delay the departure. Therefore, a decision must balance the infant's condition, the distance, and available expertise. For example, a baby on CPAP who is requiring around 40% FiO2 and a very high PEEP is better off transported after intubating and confirming the tube position before we start. Now the B, blood pressure and perfusion. Perfusion assessment includes capillary refill time, heart rate, pulse quality, skin color and urine output. A normal capillary refill time is under 3 seconds. If the perfusion is poor, initial management includes 10 to 20 ml per kg crystalloid bolus over 30 to 60 minutes. Vasoactive infusions such as dopamine or dobutamine is used when it is indicated. The key principle here is early recognition and intervention, optimizing the tissue perfusion before subjecting this neonate to transport stress. Next comes L, lab work, and the E, emotional support. Essential investigations before transfer includes blood gas analysis, blood glucose, CBC, blood culture, the alkalides, X-rays, etc. Now, emotional support is equally vital. Parents must be informed about their baby's condition, the reason for transfer and the risks involved. Allowing these parents to see, touch or even photograph their baby before transfer helps reduce the anxiety and also it fosters the trust in the system. Compassionate communication is not a courtesy. It is a clinical necessity that strengthens collaboration and understanding. Therefore, emotional support of the parents is of paramount significance in any transfer. A word about vascular access strategies. IV catheter is the most common and fastest option we have. We have to carefully consider if the baby needs umbilical catheters. Current evidence suggests minimizing umbilical catheter placement during stabilization unless essential for immediate management due to the time requirements, specialized skill needs and complication risks. Now, is there any tool to predict mortality or morbidity of transport? California Transport Risk Index of Physiological Stability or CA-TRIPS is a validated tool which predicts the same. It evaluates 5 physiological domains: responsiveness or neurological state, temperature, respiratory status, systolic blood pressure and vasoactive medication use. The scores are recorded both at the team arrival for the transfer and on NICU admission. A rising score indicates clinical deterioration during the transport, while stable or falling scores reflect good stabilization and team performance. Scores between 0 and 8 reflect low risk, whereas 9 to 16 is of moderate risk and 45 to 70 are critical risk, where the mortality may exceed 25 to 80% within the 7 days of transfer. The scoring helps teams quantify instability and provides an evidence-based method for quality auditing and improvement. Now let's consider the transport environment, which introduces unique physical and physiological stressors to both the baby and the team. Whole body vibration is one such stressor. In ground ambulances, vibration frequencies ranges from 3 to 18 Hz, and this is a stress response which is independent of the noise, and this can cause malfunction of the equipment as well. In preterm infants, excessive vibration has been linked to lower heart variability, indicating stress and potential hemodynamic compromise. Noise exposure is another hidden hazard. While the recommended sound levels are below 60 for neonatal transport, it is not often the case. Such exposure can cause cochlear damage, heart rate and blood pressure instability, and interference with clinical communication and alarm detection. During acceleration and deceleration or sudden turns, the baby experiences G-forces that can alter cardiac filling, cerebral blood flow, and venous pressure. This is particularly concerning in preterm infants who are vulnerable to intraventricular hemorrhage. During air transport, altitude introduces additional unique physiological challenges governed by gas laws. Boyle's law also explains gases expands with lower pressure by around 20 to 30% at typical flight altitudes. This risks complications such as pneumothorax and gastric distension. Hence, chest tubes and gastric vents must be in place for at-risk infants before the takeoff. Dalton's law reminds us that oxygen partial pressure drops by about 25 to 30% at altitude, potentially worsening hypoxemia. Thus, optimizing oxygen delivery and maintaining adequate hemoglobin are essential. Lastly, because cabin temperatures can fall by roughly around 2% per 300 meters of height gain, ensure that there is battery backed up heating systems and thermoneutral conditions available for these infants. Now, how do we mitigate these effects of the stressors? The first and foremost question to ask is, do we really need speed? The answer is an absolute no. The baby, especially a preterm baby, is more harmed by this reckless, fast driving with frequent accelerations and decelerations. A moderate speed within the speed limit is optimal. And please do teach our ambulance drivers before they take this transfer itself that don't go for the speed. Keep at a normal speed, avoid accelerations, decelerations and sudden brakes. Now, how do we take care of these vibrations? To counteract the vibration stressors, several isolation systems have been developed. Gel-filled mattresses offer the best performance due to their viscoelastic properties, absorbing and dissipating this energy efficiently. Air-filled systems and foam mattresses do provide some kind of vibration isolations. Some newer designs incorporate active systems that use sensors and actuators to detect and neutralizes this vibration in real time, enhancing the comfort and safety. Noise can be mitigated using infant ear protection, acoustic dampening incubator covers, and visual alarms that substitute for auditory ones. Now, what about the transport team? The doctors, the nurses, the paramedics. Transporting neonates is not just physically demanding, it is emotionally and cognitively taxing as well. Physical stressors This can include vibration, noise, confined working spaces, and motion sicknesses are very common. Over time, these can lead to fatigue, musculoskeletal strain, and even hearing impairment. Physiologically and psychologically, these team members are kind of drained. The team members must maintain composure under extreme pressures, make rapid decisions, and cope with the emotional toll of critically ill dying infant. Therefore, training programs now emphasizes critical or crisis resource management, team communication, and simulation based learning. These allows the team to practice technical and non-technical skills in realistic scenarios. Equally important is addressing the emotional burden on the families. For parents, the sudden transfer of this critically ill newborn is traumatic and disorienting experience. Pre-transport communication is essential, explaining the reason for transfer, what to expect, and how to stay informed. Allowing brief contact and photographs before the departure provides reassurance and emotional closure. During the long journeys, some programs maintain real-time communication updates to family, ensuring a transparent and comfort transfer. At receiving hospital, a smooth handover and early parental communication help establish this trust and continuity of the care. These steps transform a stressful experience into one that feels coordinated, humane, and compassionate. This brings us to the end of this presentation. Let's summarize the key principles of safe neonatal transport. Stabilization is critical. Inadequate pre-transport stabilization remains the leading cause of transport-related complications worldwide. A systematic approach ensures safety. Frameworks such as accept, stable, guide structured, organized, and comprehensive care delivery. Family-centered care is integral. The well-being of families must be supported throughout the transport process. Continuous improvement is essential. Advances in evidence-based research, simulation training, and technology continue to enhance the safety and outcomes of neonatal transport. In conclusion, neonatal transport is not merely the act of moving a baby from one place to another. It is a complex, multidisciplinary process that demands precision, preparation, and empathy. From the ancient myths of Hermes to the servo-controlled incubators of today, one principle has remained constant: the relentless pursuit of safety for our utmost vulnerable patients. Thank you for your attention. I'm Dr. Anish DL. I hope this session has given you both perspective and practical insight into the evolution, organization, and execution of safe neonatal transport. Thank you.